Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today on the show, we have Ramandeep Kaur. She is a palliative care physician, and she wrote the Kevin MD article, Patients Need Palliative Care to Manage the Pain of Sickle Cell Disease. Ramandeep, welcome to the show.
Thank you, Kevin. It's really nice to be on your show.
So we'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
My name is Ramandeep Kaur. I'm a family medicine trained physician with a fellowship in hospice and palliative medicine. Before that, I graduated from Government Medical College from India. And I started taking care of sickle cell patients in 2013 with my first job at Rush University Medical Center. As a requirement for PC and higher doses of pain medications, the patients typically need either pain anesthesia or palliative medicine to manage their pain. That's how I got involved in the treatment of sickle cell disease patients.
All right, so just walk me through a typical day of what you do in palliative care, and we'll talk about your work with sickle cell disease patients a little bit later on. But tell me about some of the common cases that you see in a typical.
Yes, so as a palliative physicians, we see patients anywhere from having cancer, anywhere from the trajectory, either from beginning of the diagnosis. And few of my patients haven't seen even oncologist first because they had such a severe pain, for example, sarcoma patients. Following their trajectory, either they recover from cancer or unfortunately they don't recover from cancer. We continue to see them over the matter of years as they're receiving their treatments like chemotherapy. Part of my practice is also hospice care, and that's with one of the private organizations here where I help manage their inpatient hospice unit. Third part of my practice is cancer clinic and palliative care primary clinic, where the cancer clinic, we manage typically cancer patients, but primary palliative care, we do manage patients who don't have cancer disease, but like sickle cell disease, extensive wounds care, various other diseases that are life-limiting, but they need pain management. So we have opened that primary palliative care like almost 3 to 4 years ago, and we started seeing patients under all the diagnoses that's kind of life-limiting, not just cancer.
All right, and we're going to talk about one of those diagnoses that aren't cancer related. In your Kevin MD article, patients need palliative care to manage the pain of sickle cell disease. Now, before I ask you to summarize our article, for those who aren't familiar with sickle cell disease, can you just give a brief introduction as to what that is?
Yes, and thank you for that, because yesterday I was giving another talk where I realized that half of the audience were not even physicians or a medical background. So sickle cell disease is it's a genetic disorder in which there is a one abnormal gene. Because of that abnormal gene, the hemoglobin turns into kind of a sickle, like a sickle shape. And because of that abnormal shape, it clogs the arteries, resulting into these vaso-occlusive crises. Patients can have these crises anywhere from every month to a few times a year, in which they will need hospitalization with IV pain medications, IV hydration, and all the medication and all other treatments to kind of overcome these crises. It's very individual. You cannot predict when a crisis is going to come, how many times it will come. There is no kind of generalizability like this many crises per year. Opioids have been the lifesaver medications. Patients with sickle cell disease will start receiving these medications as young as 6 months of age. Because of the presence of this disease itself, the patients typically have a much shorter prognosis compared to the general population. Average prognosis is about 38 years for adult male with this disease and 42 years for an adult female. That's how I will summarize how we generally look at sickle cell disease.
And let me just jump in and ask you, so if a patient comes to the emergency department with a vaso-occlusive crisis because of sickle cell disease, how do they present and what are they feeling?
That's a very good question. Actually, Sickle Cell Anemia News has an article that describes patients their own feeling in their own words. So some patients will describe that it feels like having sharp glass flowing through their body. It feels like multiple fractures throughout the body, at the same time having migraines. The females who have given birth to children, they reported that this pain is at least 10 times worse than that pain. And this pain continues till the painkillers they kick in. I have used the exact patient's word rather than my own, and as it's hard to describe someone else's pain.
All right. Now, with that background, let's talk about your Kevin MD article, and it's titled Patients Need Palliative Care to Manage the Pain of Sickle Cell Disease. Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Yes, sickle cell disease is typically called orphan disease, and there are multiple reasons. And one reason that I will kind of describe why this article was, why I even thought about this article, because there's no one physician who's taking the ownership of providing a comprehensive pain management. Hematologists and other physicians that primarily take care of sickle cell disease, they have not received extensive training in pain management. Versus a palliative who receives extensive training in how to manage pain medications has never been taught in sickle cell disease. Sickle cell disease is not in palliative fellowship curriculum, not at least till today. I realized there was a significant bias when it comes to treating the pain of a sickle cell disease patient. And it's not just the physical pain, there is a good component of non-physical pain. And the trigger point was when I heard the sickle cell disease patient being compared to a back pain patient. There is no comparison. There is no comparison, a back pain, a simple pure back pain, and a sickle cell disease patient. That triggered me that I should write down something so I can kind of advocate more for the patients that this disease is not something that could be comparable to a very benign disease. And opioid medications are something that, as you know, has been involved in an epidemic, and it continues. Despite that, we have been prescribing less and less. It has been prescribed 38% less since 2016. Opioid-related deaths still have jumped by 300%. So we need to think about what we are doing here. And actually, we are providing more harm to this population by not giving them the proper access to the treatments that kind of treat their pain. That triggered me writing this article. Few of palliative medicine background physicians has their practice is very restricted to just taking care of cancer. And we have heard this, palliative take care of only cancer patients. So it's only one diagnosis that we are very fixated on. And in no way, shape and form, sickle cell disease and cancer is comparable, but sickle cell disease patients live with worse quality of life over a long period of time, eventually dying from it. That this disease needs palliative as much as any cancer patient.
So let's say you were consulted on a sickle cell case in a hospital. Tell me what you would do differently.
I have started applying the concept of total pain in sickle cell patients. Our anesthesia colleagues does a fantastic job in managing medications. At the same time, a palliative provider can come in and assess a total pain. You will be surprised how our young sickle cell 19-year-old last week could not tell me the difference between pain generated from her emotional crisis versus the actual sickle cell pain. We cannot treat the non-physical pain with the same high doses of opioid because we are actually could be doing more harm than good. Our colleagues, anesthesia colleagues, can treat the pain with the same PCA and same high doses of medicine, but this population needs much more comprehensive approach, not just in the hospital, but also as for a continuity care and building the rapport with this population in the clinic setting as well. We can start something in the hospital. It won't materialize. It won't make a change in their quality of life unless that's carried through as an outpatient as well.
Do you see sickle cell patients who were initially hospitalized, and then do you care for them in the outpatient setting as well after they're discharged?
Yes, and that's the initiative that we started last year, Rush Sickle Cell Palliative Clinic. Due to just the staff shortage, it has been once or twice a month. Yes, I ask the patients that I see in-house to follow up in clinic as well, because that's how we can maintain the continuity of all the medications and all non-pharmacological methods that we have initiated in the hospital to be carried in the clinic setting. There are patients who may be out of network, and we have received a lot of help from case management, how to make sure that we can continue follow-up in our institution.
Now, of course, I know Rush has that connection between palliative care and sickle cell disease, but what about the rest of the country? So in general, what kind of training do palliative care physicians have when it comes to sickle cell disease?
In general, we do not receive any training in sickle cell disease. In my fellowship that I completed at Henry Ford, Detroit, there was not a single sickle cell patient that I have seen. It was something that I got started with my job, and I grew out of that comfort zone. I wanted to learn more and how to kind of expand my own self, but there is no curriculum, as I have earlier mentioned, in the palliative care fellowships. I really wish we can go there eventually. There have been some smaller hospital systems where palliative physicians have approached us, like suburbs of Chicago. Hey, I'm being asked to see sickle cell patients. Can you help me guide through how should I see? There have been at least 3 palliative care physicians that approached us, and we have helped with them with the various modules and kind of advising them what to look forward, how to start treating these patients. But in general, I have not observed palliative taking upon this responsibility. And I really wish we can go there.
So at Rush, are you routinely consulted when someone is admitted for sickle cell crisis?
Yes, our team is a primary consulting team for sickle cell disease and not pain anesthesia. Our team sees at least 5 to 7 patients on a daily basis with sickle cell crisis. We have a hematologist and good collaboration with them. We do manage patients in-house, and then majority of them follows with us in clinic.
We're talking to Ramandeep Kaur. She is a palliative care physician. She wrote the Kevin MD article, Patients Need Palliative Care to Manage the Pain of Sickle Cell Disease. Ramandeep, in the primary care setting, someone who doesn't have access to, say, palliative care, who's familiar with sickle cell disease, do you have any tips that you give to some of the primary care clinicians who may be listening to this podcast?
Yes. My biggest advice will be that we need to keep ourselves open learning more. For example, learning how buprenorphine could be really helpful in this patient subset and is something as a newer medications could be tried. And second, how we could explore the concept of total pain in sickle cell disease. Patients do not suffer just from physical pain. There's a lot of non-physical pain, psychological pain, existential distress, and social pain associated with this disease because it comes with the patient has been in the hospital at least once or twice a year. There is a no normal life for them. Some of them do not have a social support. So expanding our view on how we are treating these patients is really important. The total pain concept has been applied in cancer. I think it's a high time that we should apply it to cancer disease as well.
And when you talk about these non-physical sources of pain, give us some concrete examples of what you could do to help with that aspect.
I will take an example of the patient that I have seen last week. She was a 19-year-old, and her crisis was triggered by an emotional distress over an issue with a friend. And I asked her what triggered the crisis, and that's what she mentioned. Her lab work did not show any hemolysis. Typically, the pain of sickle cell is not diagnosed with any lab factor. It's a patient's word and the family's word that, yes, someone is in pain. At the same time, I was able to ask her various kind of motivational questions. What triggered? What happened? How you ended up in the hospital? And how are you feeling different right now? At that point, she was able to diagnose, she already had a history of depression, that there was a component of anxiety that actually triggers her pain, and she was treating her anxiety with IV opioids. That was something that patient was never told how to distinguish before, and IV opioids are the only medications that were available to them. Not that we should not treat these patients with actual hemolytic crisis. At the same time, we need to use our motivational questioning. What other things they are feeling at the time of having a crisis? How is their mood? How was it different a week before crisis? How they're feeling today, 3 days after admission, 4 days after admission, and that will help you kind of draw the answers that what else is going on in this patient's life.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
Sickle cell disease has been called orphan disease, and it will be called orphan disease, I believe, for a longer time. from now onwards. This is a time that as palliative providers, we should use our comprehensive approach for this patient population, for their overall patient management, as we provide for cancer population. We have the skills, we have the ability, we have the empathy that this patient population needs, and that will be my kind of final advice to this listeners. Thank you.
Ramandeep, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you, Kevin.